Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, dear viewers, ladies and gentlemen. Happy and blessed Ramadan. Dr. Mohammed AlSheef, your host of Elixir of Life from Saudi TV Channel 2, is kicking off another inspiring and informative episode with our distinguished guest, aiming to explore new frontiers and bring you most up-to-date information related to health. Our topic tonight is very important: pituitary gland disorder, with our esteemed and distinguished guest, Dr. Hussein Raref. Stay tuned for a special episode. Once again, welcome back to Elixir of Life. Our next segment will be Quote of the Week. To watch more details about this quote, stay with us. Once again, welcome back to Elixir of Life. Our next segment, which is the most important segment, our episode theme, will be talking about thyroid disorders or pituitary gland disorder. Pituitary gland is the master gland of the body. To know more details about its clinical presentation, about risk factors, how treated, how investigated, with our distinguished and esteemed guest, Dr. Hussein Mohammed Raref. He's consultant endocrinologist, King Faisal Specialist Hospital and Research Center. And he's my teacher, and proud to say that. Welcome, Dr. Hussein.
Thank you, Dr. Mohammed. We're proud of people like you who were students and now in a very esteemed positions. And I would like to welcome your audience, and happy and blessed Ramadan to everybody. So pituitary, as you mentioned, it is really a very important gland. We call it the queen. So this came from its ability to control other glands. So every other endocrine glands, and endocrine mean a gland that secretes hormone inside the blood, is controlled indeed by the pituitary. So that include the thyroid gland, include the gonads for women and men, ovaries in women and testicles in men, and also include special hormones secreted directly from the pituitary, like prolactin hormone, which is the hormone of milk, we call it, and growth hormone, which is responsible for development and growth of the humans. So any of those, any problem with the gland can affect either one or two or three or every other gland.
Very interesting, Dr. Hussein. What's the control room or the structure or anatomy of this gland? Where is it? Okay,
so this is a very small gland, surprisingly, in spite of its very important function, and it resides just at the base of the brain, so at the skull base. If you take maybe kind of an imaginary line behind the nose, there are sinuses, and behind these sinuses there's a small area in the bone at the bottom of the skull. We call it the sella turcica, which means like it is
chair, like
it's the chair, yeah. It's like the saddle on the horse, and in that saddle there's this very small few grams gland that sit there and connect to the blood and to the brain in the same time. I didn't mention, but it has another function, which is the hormone that control our ability to drink or to preserve water. So if we lack that hormone, we get something called diabetes insipidus, which probably we'll talk about. It's a condition where we cannot control the amount of urine we excrete.
So this is a very, small structure, but
Yes.
it's very important.
That's correct.
Controlling all, endocrine glands in the body. So is it, for structural, and functional reason, is there any classification, anterior, posterior, or it's just...
Sure. So structurally, sitting in that little saddle or small house, it has actually a part which is, we call it the front or the anterior part of the gland, and that part is connected to the brain, to another higher center of the brain, and that one secretes number of hormones. It secretes the prolactin, which is the hormone of the milk, we said. It secretes growth hormone, which is very important for growth, height especially, and it secretes the FSH and LH hormones, which control either ovaries or testicles in women and men.
Mhm.
And it secretes also ACTH. It's a hormone that controls the adrenal gland. So you have a whole bunch of things here. Now the part which is the posterior part, it's more a nervous type of tissue. So it connects also to the brain, and this is where the hormone for the conservation of the water, we call it ADH hormone.
ADH.
This is where it's
Antidiuretic hormone.
That's correct, and secreted from there.
Excellent. What types of pituitary gland disorders?
Okay, so pituitary sitting there can have a number of problems, unfortunately, like any other gland. So this gland can become over-functioning. That is, one of those hormones, usually one, not all of them, become over-secreted. And what is the reason? Usually it's a tumor, small tumor. Luckily, it's a benign tumor. They're not malignant. 99.9%, these are benign tumors. But why they are important? Because whatever they secrete can affect the body. And we will take some examples for this. But also the location. So a tumor in that area, very close to the optic nerve, where the two optic nerves cross, we call it optic chiasma,
Yes.
and therefore can affect the vision if it becomes too large.
Visual field.
Yeah,
defect.
so many patients will come not because of the hormone, they will come because they start to have visual issues or headache, as example.
Due to compression, okay?
That's correct. So if we talk about over-functioning, we'll take some examples of this.
Hyperactive, yes.
Correct. And there's also under-functioning. There are many, many other reasons, maybe more than over-functioning, that the gland become under-functioning, either with one of the hormones, or two, or three, or everything. Also, the posterior part can become defective, and the patient or the person becomes so thirsty, he will make a lot of water, urine, and that urine will be very diluted, like water. And we have to replace them with the hormone that's lacking. Otherwise, they will continue to have miserable symptoms. So these are the diseases that the gland can have. And if we go on what can cause these diseases, these are tumors, again, benign tumors normally. It could be inflammation, but also could be something that happened from outside, like surgery, like radiation. And there are other rare diseases that could be congenital or hereditary that can also affect the pituitary gland.
Beautiful. Dr. Raref, so if you mentioned pituitary gland disorder like hypoactive or underactive or hypofunctioning, which hormone that to be affected first and which one to be, preserved at the last, okay?
Okay, so let's talk about hypofunctioning since it is more common. We'll come back to the hyperfunctioning, which is usually fascinating to the physicians.
Dramatic.
Because they are rare but very kind of unusual diseases. The hypofunction can affect, as I mentioned, 1, 2, or 3, or all the hormones. So the most vulnerable hormone, the hormone that really can be affected, would be growth hormone. Growth hormone may be the first,
yes.
and will be followed by other hormones. Of course, prolactin can be deficient, but that's not very important. Growth hormone deficiency is very common. then you can have probably thyroid hormone affected, and the most resistant will be the ACTH that produce the cortisol from the adrenal gland.
Mm-hmm.
Now, this is usually how we see it. So some people will have growth hormone deficiency, they will have thyroid hormone deficiency. Definitely the gonadal also are very, very sensitive. They probably come after growth hormone, before the thyroid.
Mm-hmm.
And at the end, we see people who have cortisol deficiency due to the pituitary dysfunction.
Great, excellent. Very beautiful. And what are the pituitary gland, I will say, risk factors, pituitary gland disorder risk factor or causes?
Yeah. So what causes hypopituitarism, what we call it, or deficiency in a pituitary hormone? I think we're seeing much more now with the development of a lot of treatments for, let's say, child cancers. As you know, children can be affected with brain tumors, head and neck tumors, and now we see a lot of survival because of surgery and chemotherapy, but they end with pituitary dysfunction as well. So this is a large, actually, number of patients that we see due to iatrogenic, we call it, something that we caused by treatment, by radiation, by surgery, but even by trauma, accidents can lead to dysfunction of the pituitary.
Very beautiful.
There are also diseases that can occur there, and the most common are tumors. So there are tumors that happen in the pituitary that do not secrete any hormones, or they might secrete one hormone, but they cause damage to the rest of the pituitary gland. So this patient could have excess cortisol or ACTH, or what we call Cushing disease, but he has also deficiency in other hormones. Or acromegaly, which is excessive growth hormone, but he has also deficiency in other hormones. So we see now a fair amount of those patients who require replacement of their hormones.
Very beautiful. What are the symptoms of, let's say, pituitary gland disorders, whether it is hypoactive or hyperactive?
Yeah. So patients present differently, and they can present due to a big mass in the pituitary gland, and those patients can maybe present with headache and visual changes because that gland push on the optic nerve and cause deficiency in their visual field, especially if they're driving. If they're drivers or they drive a car, they may not see on the sides. So they see in the central, but they don't see on the sides. That's one presentation. Women present a little different from men. So men usually present this way because of headache or visual changes. Women come because of irregularity in their menses. Menses stop or became irregular, became very few. And women are so sensitive to this issue, so they come early, and they present earlier than men with pituitary dysfunction. Or you can have presentation due to the low hormones. So symptoms of hypothyroidism, low thyroid, weakness, weight gain, excessive fatigue can be presentation. Hypogonadism is a very common presentation, especially in women. As we said, menses stops because the gonad hormones, the hormones that do the cycles, the ovary cycle stops, so there are no more cycles. Men also because of decreased sexual drive or infertility even, inability to have children. So that can be a presentation. Then you have the rare presentation with the hormone itself being overproduced. Then you have the kind of fascinating syndrome, as we call them, like acromegaly, somebody who has excessive growth hormone. So if they have it before puberty, they become giants. We call it gigantism. If they have it after puberty or after their bone actually closed, so they cannot grow in height anymore, they have the symptoms of acromegaly, which is usually excessive headache, increase in the size of the hands, increase of the size of the head, certain changes in the features of the face,
spacing
of the and increasing in the size of the jaw. Usually, if they put a hat or they put a gal, they might really notice that it's increasing in size. The shoe size can increase, and so forth. They might even present with complication from the hormone. So as you know, excessive growth hormone can cause heart problems or arthritis. So commonly they might come from the ophthalmologist because of eye. They might be referred from the rheumatologist because of arthritis issues, and he suspected, he was smart enough to suspect the rare disease.
Diabetes they might have.
Right. Now, if they have excessive ACTH, which causes excessive cortisol from the adrenals because of this hormone that make the adrenal functions, then they present with Cushing, what we call Cushing disease. And this is also depends on age. So a child with Cushing disease will present with inability to grow. He will become obese and does not grow. An older one will have the features of Cushing disease, which is again weight gain, change in the face, the position of fat in the center of the body, but not in the legs, muscle wasting, inability to climb stairs because of muscle weakness, and so on.
Very beautiful. It's wide range, you know.
Very wide range, very wide range. And I think physicians should be extremely have low threshold vigilant, for suspicion and vigilant. And for the public, they should know enough to suspect. I mean, we don't expect people to make the diagnosis, but at least to suspect it sometime.
Excellent. Because there are some, you know, celebrity or let's say characteristic, you know, feature like Giant, you know, Andre the Giant, okay, maybe he's one of the, you know, victims or patient with acromegaly, okay.
That's correct. So gigantism, that's something easy to spot because here's this child who's growing much, much faster than usual for the family. So in that case, it should be suspected. I should say that this disease is extremely uncommon. It's probably 1 per hundreds of thousands. So it's not a common disease. However, when it presents, it creates a lot of problems for the patient.
Beautiful. You mentioned many times it's not common disease. How common pituitary gland disorders generally?
Yeah, I'm not sure I have exact figure here, but of course, if we're talking about Cushing disease and acromegaly, these are the excessive hormone, growth hormone, or excessive ACTH cortisol hormone. These are extremely rare. We see them in a center where we get referral, but normally, as a physician, he will see 1 or 2 cases all his life.
Career, yes.
So they're 1 per hundreds of thousands. However, prolactinoma, which is another type of tumor that happen in the pituitary gland and secrete prolactin, which is the hormone, we call it the milk hormone because it has something to do with the breastfeeding. It's much more common, and people do have this much more common. Then we have those tumors who does not make any specific hormone. We call them non-functional, and all what they do, they present because of their mass effect, because of their pressure on the other pituitary gland or on the visual field. So altogether, plus the low-function pituitary, which is not uncommon, probably one of the most common brain disease, if you want, then I think you have a fair number of patients who are taking replacement for pituitary dysfunction these days.
Very interesting indeed. Dr. Hussein, right now after the clinical presentation of pituitary gland disorders, let's say I'm a physician, okay, how to investigate such patient, laboratory or radiology investigations?
Okay, very good.
The line of investigations. Yeah.
Right. So again, it's a wide spectrum because of the wide spectrum presentation, so it depends how they present. So somebody who's coming with severe headache, visual changes, of course, radiology is the first thing to do. And usually the ophthalmologist or whoever sees the patient will order that X-ray to be sure there's nothing wrong in the brain, and they will find a tumor, small enlargement of the pituitary gland, so they can spot it easily there. However, if this is not the presentation, if the presentation comes as let's say we're suspecting over-functioning of the gland in a certain way. So let's say a woman come with irregular menses and excessive breast secretion from the milk, so we're suspecting prolactinoma. We order that blood test, prolactin. In general, we say, and this is especially common saying for endocrinologists, that we like to make the diagnosis before X-ray.
Sure, laboratory before
right,
radiology.
Because I will talk later on about just throwing X-rays right and left has really caused problems because we're finding things that we don't know what it means. We'll come back to this point maybe later. Yes. So if we suspect a special disease, let's say excessive growth hormone, so this is a child that's growing very fast, or an adult who's having increase in the size of his hands, shoes, and also has other features suspicious for the acromegaly. So all what we do is check that hormone. And each one of those hormones has a specific way to check. So it's not just a hormone you throw. So growth hormone alone doesn't mean so much. We do other markers for the disease. We do it after giving the patient a meal or certain amount of sugar, because normally the growth hormone will go down, but if there's a tumor, it will go up. So there's different way of making the diagnosis. If the patient comes with a low function symptoms, so somebody who's feeling so weak, lethargic, tired all the time, fatigue, we check his thyroid function test and we check his cortisol in the morning. If we find it low, we do further testing. When we confirm the biochemical picture, usually the next step is imaging. And the best way to image the pituitary is MRI, the magnetic resonance imaging, because it has very good quality to show you the details of the pituitary gland. We said the pituitary gland is 1 centimeter gland. Then you can imagine if there is a little tumor there. Some of these tumors are only 2 or 3 millimeters, but they still secrete a lot of hormones. They can cause a major disease, and we may not be able to find it on, let's say, CT. So we like MRI because it's more accurate and can go through the pituitary, slice it, and can discover tumors as small as 2 or 3 millimeters.
And what's the, sometimes we say macroadenoma and microadenoma.
Yes.
What's the implication for this?
So there's a lot of implication. So these tumors can be very small, 2, 3, 4 millimeters, 5 millimeters. Anything less than 1 centimeter, we call it microadenoma. Anything above 1 centimeter, here's now the size of the tumor is becoming even more than the size of the gland itself, and start to go up beyond that little chair that it should sit there, and start to affect nerves, that especially the optic nerve. So this is a macroadenoma. So obviously, they both can be secreting, they both can be non-functioning, but from management point of view and from symptom point of view, they can be different. Surgery, if the patient ends with surgery, is much easier when the tumor is small. When the tumor is large, the chance of cure by surgery is less. So there is implication also in the outcome of the surgery, and of course the type of symptoms the patient might have.
But not related to functionality, that it's micro more functional, micro less functional, or
no. So you can have a prolactin producing tumor that's 4 millimeter, and you can have a giant one which is 4, 5, 6 centimeter all over the brain.
No correlation.
Both are benign, but you can see the difference between a small tumor and a tumor that's invading the brain. Although it's benign, it can be very, You
brought a very important topic, that you are against gunshot approach, that you send hormones. Generally, you are tailored, you're tailoring the investigation according to your clinical presentation. Am I right, Dr. Raref?
That's correct.
Yeah.
As much as I suggest to be a little bit low threshold, meaning to suspect things and to do the screening for these, because some of them are rare disease, and unless you have this suspicion, you will miss a lot of cases, actually. But on the other hand, doing so many testing, not to mention the cost of these tests on health.
Very costly.
Yeah. But also, if you keep doing x-rays without good reason, there are about up to 10% of people who might have small lesions in the pituitary gland, 2, 3, 4, 5 millimeters, doing nothing. They will never do anything the rest of their life, and now we're stuck with something we don't know what it is. So we start doing all these blood tests, follow-up x-rays 1 year and 2 years. We call it incidental tumor or incidental adenoma, and usually it takes 2 years of work to kind of say, quit, there's nothing there.
Yeah, it's like there is a nice metaphor. They say that such discovery, like you are cracking a nut with a jackhammer. So this is a tiny asymptomatic pituitary gland tumor,
right,
but we are over investigating radiology, laboratory, and sometimes requiring unnecessary surgery.
That's true. So of course we accept that this is going to happen because now we use the X-ray, the MRI much more than before for different reasons. And we will find some of those tumors, so we can deal with them, but we discourage to do these tests unless there is a good reason to do them.
Absolutely. What's the rationale of the diurnal, variation of, you mentioned that the cortisol should be checked in the morning. Is there any diurnal variation in the secretion of the pituitary gland hormones?
Yeah, so almost all hormones are secreted in rhythm.
Circadian rhythm.
Yes, and some of them in pulse, actually, very, like growth hormone is secreted in pulse.
Beautiful.
And the circadian rhythm means that there are changes in the hormone secretion according to the day-night cycle. So as example, cortisol is a classic example for this. We have the highest level of cortisol in the early morning when we're supposed to be active and going.
Beautiful.
And we have the lowest level later in the evening when we're supposed to be resting. This is how our body has adjusted over the years. However, of course, with our lifestyle, sometimes we disturb that circadian rhythm. Many travels between west and east, the changes in the day-night, the jet lag, so on and so on. So we use this circadian rhythm to diagnose certain diseases. As example, Cushing disease, which is cortisol for production. The best way to screen for this disease is to measure cortisol at 11 p.m. We're supposed to be very low, and if you have a high level, even normal level, upper normal level, is considered abnormal.
Very beautiful.
And it's the best screening test for Cushing disease.
That's very beautiful.
Yeah.
Dr. Hussein, Raref, please excuse us to go for a report for symptoms of thyroid problems for women. To watch more details about this report, please stay with us.
Thyroid Treatment for Women presents How to Tell If You're Suffering from Hypothyroidism. Or, put another way, what are the symptoms of low thyroid? Millions of people suffer from hypothyroidism and don't even know it, or they've been told by some uninformed doctor that their thyroids are just fine. If you have many of the low thyroid symptoms we will discuss here in a minute, even if you've been told by your doctor you're fine, at the end of the video I'll show you how to take your life back in a natural and holistic way. The signs and symptoms of hypothyroidism vary depending on the severity of hormone deficiency, but in general, any problems you have tend to develop slowly, often over a number of years. At first, you barely even notice the symptoms of hypothyroidism, such as fatigue and weight gain, or you may simply attribute them to getting older. But as your metabolism continues to slow, you may develop more obvious signs and symptoms. Hypothyroidism signs and symptoms may include dry skin, unexplained weight gain, puffy face, hoarseness, muscle weakness, elevated blood cholesterol levels, muscle aches and tenderness and stiffness, pain, stiffness, and swelling in your joints, heavier than normal or irregular menstrual periods, thinning hair, slowed heart rate, depression, impaired memory, fatigue, sensitivity to cold, and constipation. While these aren't a complete list of symptoms, this is a pretty comprehensive list. When hypothyroidism isn't treated, signs and symptoms can gradually become more severe. Constant stimulation of your thyroid gland to release more hormones may lead to an enlarged thyroid, often called a goiter. In addition, you may become more forgetful, your thought process may slow, or you may feel depressed. Knowing the symptoms is the first step in making changes necessary to reverse these problems. The good news is, most of these symptoms can be overcome with a natural and holistic approach to healing.
Once again, welcome back to Elixir of Life and our topic, pituitary gland disorders, with our distinguished guest, Dr. Hussein, Raref, consultant endocrinologist from King Faisal Specialist Hospital. Welcome, Dr. Hussein. Just to continue the discussion about what are the causes of pituitary gland disorder, particularly hypo or underfunctioning.
Yeah. So we mentioned a number of things, but if we try to put hypopituitarism or underfunctioning pituitary is the most common issue in pituitary disease, and can be caused, as we mentioned, in any tumor, whether functioning or non-functioning, that has destroyed the rest of the pituitary gland. But we see it after radiation, for whatever reason, cancer or whatever in the head and neck area. We see it after surgery to remove a pituitary tumor that can damage the rest of the pituitary gland. There are also a bunch of unusual diseases that cause inflammation. Not infection, but inflammation, meaning reaction in that area due to disease that affect the whole body. So there are diseases like sarcoidosis, as example. We call them granulomatous disease, TB. Can affect the pituitary gland itself and can cause underfunctioning of the gland. In pregnancy is a kind of interesting disease that happened during pregnancy. We call hypophysitis. But now we know it does happen even without pregnancy. We know now it happens even in male, not just in female, and cause inflammation of the pituitary gland. So it's swell, but it's not a tumor, it's just an inflammation. Unfortunately, although it usually subsides, but it causes hypofunctioning. There are also a bunch of hypofunctioning hormones that happen during childhood due to a decrease of what we call cofactors. These are things that happen, if you image the pituitary, it looks normal. But there's something lacking, small protein or cofactor that is very essential to produce certain hormone. So they can have, again, 1, 2, or 3, or 4 different hormone deficiencies.
Very interesting indeed. Now we are coming to the most important question. What's the management of pituitary gland disorders?
So we'll stay with the quotation that you put, that treatment is the most important, of course, and I'm sure audience will be more interested in this. Fortunately, there is a treatment, and there's a good treatment for almost everything we mentioned. So this is why it's important to diagnose, because there is a treatment. So if we have an overfunctioning tumor, normally tumor should be resected with surgery, and surgery are maybe I should emphasize this. These surgeries should be done by the most expert neurosurgeon, a neurosurgeon that does this type of surgery, because it makes a whole difference between a successful surgery and not very successful surgery. Is the experience of the surgeon. Surgeon that's doing this surgery, usually they go, we call it transsphenoidal surgery. They go through the nose or just below the eye, and they go through the sinuses without opening the brain and the head or the skull otherwise, and they go to that area under the microscope and resect that tumor. The only exception for this is prolactinoma, those tumors that produce the prolactin hormone, because they are totally treated and cured, or at least go in complete remission with medical therapy. No need for surgery most of the time. There are exceptions, but most of the time medical therapy is very essential, even for large tumors. They can shrink, the hormones will go down gradually, and most of the time, or many times, the patient will have the pituitary function again going back almost to normal, unless there's a destruction before the treatment. So that part for the tumor, either surgery or medical therapy, depends on the type.
So Dr. Raref, if you allow me, so there is no need nowadays for craniotomy. It is all minimally invasive through transsphenoidal or transnasal, as you
That's correct. So this is now the surgery that's done unless we have a very large tumor. And in one type of these tumors that sometimes require craniotomy is called craniopharyngioma. Craniopharyngioma happen during childhood, but also can happen in adulthood as well. And those tumors are cystic and they're a little bit high. So they come from above rather than from the pituitary. And sometimes the surgeon has to do it through craniotomy, which means opening the skull.
Excellent.
But majority of the pituitary tumors are resected through transsphenoidal surgery, which is not through the skull.
Excellent.
Are there other medical therapy for these tumors? Yes, because sometimes we cannot cure them with surgery, unfortunately. So we have to use medical therapy. There's medical therapy, depends on the type of tumor that we have. Unfortunately, now we have very effective medical therapy. Just to take an example, patient with acromegaly. Many of them are not cured by surgery, and they still have excess amount of growth hormone, and we can treat them with an injection that's every 4 weeks. We give them an injection.
Which is?
This is like octreotide. This is a hormone that suppresses growth hormone. So it's made in long-acting hormone, and it's injected once a month.
Sure.
There are other type of treatments which are very specialized, but maybe the most important to the audience is the replacement of low hormones, because this is more common. And each of the hormone that is deficient we can replace, fortunately. So starting with the hormone that's we call ADH, that is very important to preserve water. We can replace it in the form of pill under the tongue, or a pill that you can swallow, or even a nasal spray. So there are different forms. We call it DDAVP or vasopressin. We come to thyroid dysfunction. This is very easy replaced, like even the diseases of the thyroid. When you have underfunctioning thyroid, you give thyroxine. So also we give thyroxine when there is a deficiency of TSH, which is the hormone produced by the pituitary. If there's a cortisol deficiency due to ACTH deficiency, then we replace with cortisone. Cortisone is the most tricky one in the replacement, because there are different ways of, some people use more long-acting, like prednisone, once a day. Some, and now this is the trend actually, to use shorter-acting cortisone, like hydrocortisone, and give like 2 to 3 times per day at higher than smaller dose.
Sure.
To try to mimic the normal body physiology. Gonadal hormones are maybe the most difficult to replace. Why? Because although you can give estrogen to women, you can give testosterone in the form of injection or as a gel or a patch for the male, restoring fertility is probably something would be very important for the patient. A lot of those patients are young women and men, and they have not achieved fertility, or they have 1 or 2 child, and they might have discovered the whole thing after their marriage. So how do we restore fertility? We can restore fertility indeed by giving these hormones lacking from the pituitary in form of injection. And we have many patients who are able to conceive or to have their wives conceive after treatment. So there is a lot of hope, although the treatment is not so easy.
Excellent. What's the because since we are in Ramadan, what's the best time of the day to take my hormone replacement therapy?
So Ramadan, as most of the other medications, you have to distribute them in a certain way. So there are two medications that are a little tricky, which is the thyroxine, because we always tell patients take it on an empty stomach to get the most absorption. So now they ask, when should I take it then? Well, you can take it at iftar time because the stomach is completely empty, and you can start with taking the pill with some water, wait 15, 20, 30 minutes if you can, and then just take your food, and I think that's sufficient. In a normal way, of course, we tell them to take it early morning when they wake up. For the cortisone, again, maybe depends on the style of the patient who's going to work during the day or is not going to work during the daytime. But in general, I would say to take the higher dose of the steroid at the iftar and a smaller dose at suhoor. Unless he is expected to work right after suhoor or shortly in the early morning, then it might make sense to just reverse it.
Sure, beautiful. Now after the management, whether it's surgical or medical therapy, what's follow-up for such a patient? Is it lifelong follow-up or just short-term?
So, yeah, most of those patients will require lifelong follow-up. So somebody who has a tumor, even if it's cured by surgery, they might come back. So we continue to follow them at least on a yearly basis. Many of them, I would say at least half of the patient will not be cured completely, especially if they have the growth hormone secreting or ACTH cortisol over secreting. And they might need medical therapy to continue their therapy to control this excess hormone. So definitely they will need long-term surveillance. Plus, some of this excess growth hormone can have complications. So somebody who has excess growth hormone will need to screen them for any excess growth in their colons, breast for women, and so forth. So they need also to be screened and followed. If we do so, if we are able to bring their hormones close to normal, they will have fairly normal life expectancy and they will have normal life. Otherwise, they might have a lot of complications. For the rest of the patients who need replacement for the hypopituitarism, then definitely they will need these replacement, and they need to follow the physician, at least primary care, but many times a specialist, to be sure that they are maintained well for their life.
So follow-up is very important.
That's true, and that's probably what I would like to emphasize. Yeah.
And would like to get the take-home message from you, Dr. Hussein.
Yeah. So this is a combination of rare and not so rare diseases. Certainly they are so interesting to healthcare provider. They might be quite challenging for patients. As example, Cushing disease, excessive cortisol can be very challenging to patient family. So I would say early diagnosis, and my message to the health provider first is to keep their suspicion of these diseases, to do the screening whenever they suspect the disease, and whenever they think they have a case, to refer to the specialist. This way we can diagnose those cases earlier and maybe we have better outcome. For the patients, I would say stick with your physician. It's a lifelong journey. However, the outcome is good. And those who have oversecretion, if we normalize their hormones, they will have a very normal life for most of the time. For those who have under-functioning, replacement is available, and there is no reason for them not to have a fairly normal life.
Thank you, Dr. Hussein Raref, for enlightening us about very important topic. It was such a wealthy, discussion, and it was a great pleasure and honor being with us. I'm really grateful and appreciating for you being with us.
Pleasure is mine. Thank you very much.
Thank you. Now we are coming to the next segment of our program, Health Benefit. To watch more details about this report, stay with us.
Our sisters can be especially concerned about the state of their hair, skin and nails during Ramadan. There are a few essential nutrients that you can help maintain healthy skin and nails. Vitamin A is one of the most important vitamins for skin health. It prevents skin dryness and dehydration, in addition to giving your skin a smooth, soft texture. Carrots are the richest source of vitamin A, so during Ramadan it is good to include fresh carrot juice in your juices menu at least once or twice a week and add them to your salad at iftar. Other vitamin A rich foods include spinach or molokhia. B vitamins. A deficiency of these vitamins can lead to skin dehydration, the early appearance of wrinkles and premature aging. Important sources of B vitamins are meat, beans and whole grains. So include lean meat, grilled chicken and fish in your main meal, as they are the richest sources. Get the benefit of whole grains by replacing white bread with wholemeal bread. Vitamin E, another essential vitamin. It helps minimize the appearance of wrinkles and enhances cell regeneration. Vitamin E is found in nuts and vegetable oils that you use in your cooking. Vitamin C, this vitamin plays an important role in maintaining the integrity and glow of the skin. Vitamin C rich fruit juices include orange, strawberry and melon juice. And water. Water, water, water. It is essential to drink plenty of water to prevent your body and skin from dehydration, especially during Ramadan. Water also helps you preserve the skin's elasticity and protects you against the early appearance of wrinkles.
Once again, welcome back to Elixir of Life. I wish you found our episode useful and enjoying. And always I say awareness is the best prevention. With that, we are coming to the end of our show. Before that, I would like to appreciate and thank our distinguished team. Mohammed Al-Qasimi, sound, lighting, Mohammed Al-Athman, cameraman Salim Al-Arabi, and our director Saghir Al-Shahri, and my pleasure, Dr. Mohammed AlSheef was your host. Looking forward to see you next week. Until next week, I wish you a pleasant week ahead. Assalamu alaikum wa rahmatullahi wa barakatuh. Goodbye.